Hi, good morning. Welcome to the 2020 Behavioral Health Symposium. I'm not sure if you participated in my session earlier, but I wanted to introduce you to the person-centered planning training that we have today that is going to be facilitated by Virginia Selleck and Peggy Swarbrick. This is for all quality purposes. I want to go through some housekeeping items that I did not get to go through earlier, for which I apologize. All participants will be muted. Please utilize the Zoom link on your computer for questions, answers, and if you have any comments, I'm going to do my absolute best to be monitoring for questions throughout the session and be able to get that over to Dr. Selleck and Dr. Swarbrick for their feedback today. This session is accredited for 1.5 hours of CEUs for social workers, LPCs, peer support specialists, psychologists, and nursing contact hours, as well as AMA, PRA Category 1 credits. For full participation is required to receive credit and will be monitored throughout this session. You will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Additional information is available in the digital booklet that has been provided to you. So with that, just a couple of other things. Virginia Selleck and Peggy Swarbrick have no financial disclosures. None of the members of the symposium's financial disclosures. Bios. Dr. Selleck has worked in the rehabilitation field for over 40 years. She has experience in psychiatric rehabilitation and recovery systems reform, program development, implementation, funding issues, legislation, and policy. She has held leadership positions in state government, both in Minnesota and in Missouri, and will with community mental health providers like in rural Illinois, urban Chicago, and St. Louis. She has also provided independent consultation to multiple other states, and most recently being in Nebraska. Dr. Selleck has a particular interest and background in the implementation of evidence-based practices for psychiatric rehabilitation. Currently, Virginia works on a contract for CONASYS under the Department of Labor's Office of Disability Employment Programs and has been a subject matter expert for a number of states, most recently Iowa, Wisconsin, Indiana, and Colorado. She works with the Technical Assistance Collaborative to support the state of Louisiana on the Department of Justice initiative. She has extensive speaking, training, and consulting experience in a number of states about various issues germane to psychiatric rehabilitation, employment in particular, and other systems change. Virginia has a PhD in counseling psychology from the School of Education and Social Policy at Northwestern University and a master's degree in rehabilitation counseling from the Rehabilitation Institute at Southern Illinois University. Peggy Swarbrick is the Wellness Institute Director at the Collaborative Support Programs of New Jersey. Dr. Swarbrick has published and lectured around the country and internationally on wellness promotion models, employment, peer support, and recovery. Her work is focused on a recovery-based eight-dimensional wellness to promote recovery from mental health and substance use conditions. She is well known for collaborating with the peer community and family groups to identify and address social determinants that present barriers to recovery, such as homelessness, poverty, and unemployment. She has created health promotion initiatives and has created wellness self-care programs for caregivers, family, and youth. She has made significant contributions to the body of literature in occupational therapy, nursing, and community mental health practice. Welcome, Dr. Selleck and Swarbrick. We're so happy to have you today. And I'm going to go ahead and take my video off, mute myself, and let you all go on with the presentation.
Thank you, Anne. It's great to be with all of you people. I'm coming to you from Chicago, Illinois. We're expecting some rain, so if you hear thunder, that's what's going on. As Anne foreshadowed in her first session, and I'm sure all of you are aware, we're working with the state of Louisiana to really help the state move forth the way they're working to create a system that really provides the most individualized and recovery-oriented kinds of care for the people that you serve. And a big piece of that is person-centered planning. What they have asked us to do and what we did was create a training, multiple training sessions around person-centered planning. What we have created is essentially a 3-module or half-day training. But today, what we are going to offer you guys is a distillation of that training. At a future time, you'll be hearing from Ann or others about how to access the full training, which we will be offering to the state, and it will be a train the trainer approach, meaning that we will not be running around your state. Instead, we will be making sure that your trainers in Louisiana have access to the specific information that we've put together for you. And so the training is a scripted training so that whenever the people in Louisiana get this, it will be systematic and it will be consistent throughout all training opportunities. So just want to let you know that that's kind of how this is going to roll out. The way we're going to handle it today is that Peggy and I will be tag teaming. She will be moving the slides. I will be offering some introduction. She will say a few things. Then we'll take turns. I will have a big chunk, and then Peggy will have a big chunk, and I'll be back at the end. There will be a time or two in this where I believe we will ask you a question that you can use the chat box to answer. We know that our Zoom technology, while it is miraculous in the sense that here I am in Chicago talking to you folks down there, and I know you're all in different parts of the state, still it's a little awkward compared to being in real life when you can really freely interact. So we're going to do the best we can to be as present to you as we can. And we hope that you will enjoy this presentation and that you will find something new to think about in it. So I'm going to begin. The purpose of this training is to help service providers learn skills to ensure that the planning and subsequent service delivery for each person you serve is driven by the hopes, dreams, aspirations, wishes of the person receiving the help. That is a long description of the essence of what is person-centered planning. It is a collaborative process where people using behavioral health services participate in the development of service goals and in the selection of the services that get provided to the greatest extent possible. Key factors are that person-centered planning is strength-based, and it focuses particularly on the individual's abilities and their preferences and goals. The individual using the services and their significant others are core participants in the development of the goals of and plans for treatment. You will hear us returning to that theme throughout, that the person-centered is really at the center. We hope to provide you, and by extension, the people you are serving, with the most current methods of support that will lead most rapidly to recovery outcomes. We know from experience that change is hard. We've all had to change as we go through our lives and our practice. And we think it's possible that some of the suggestions that we're going to offer in this training might require changing some of your language or your other routine practices. We all know that just as hand washing was a big revelation back in the olden times for doctors, took a while for people to get used to that. Some person-centered practices, and not only that, evidence-based practices, can seem like big changes, but it's what we need to make progress. So we're going to begin with an overview of the wellness model that forms a framework for person-centered care. We'll talk about the concept of recovery and how it is supported by person-centered planning, and we will talk about what is involved in the person-centered planning process. And to let you know that research has shown that this philosophical and practice framework is more successful in helping people achieve recovery outcomes, and it's also a key underpinning in other evidence-based practices. And just to also let you know, we do have references that could be available to you for things that we mentioned. If you're wondering where we got the research or where we got the information, that would be available to you at another time. So our learning objectives today, oh, Peggy, you're going to take the learning objectives.
Yes. So here's just the objectives. Being person-centered planning is a collaborative process. So what we're going to do is we're going to learn about the definition of what person-centered planning is, the 4 P's: philosophy, process, plan, and purpose. And there's a handout we'll give you that really illustrates it quite nicely. You'll see. we're going to do a little bit of an examination of the history that led to this approach. It's important to see where we are historically in terms of how we got here, and really the using the 8 dimensions as the lens. We're also going to touch on the idea in terms of this process as the golden thread of medical necessity that fits here. So really important. Well, hopefully you'll be identify the importance of using this strength-based approach in the work that you guys are doing already, or that you're going to be continuing to do and grow. So Virginia's going to take us.
Okay. We'll now start with the subject of language. We want to kind of touch on this just briefly. Many service providers, many of us, have been trained to be sure to use quote unquote clinical language that really tends to be focused on symptoms and problems. However, what we now know is that that focus may not reflect the things that most concern the person that we are serving. So it is important, but it is sometimes challenging to find ways to put the person's own words into a format that seems appropriate and is also billable. So this training is going to provide guidance about how to keep the person served at the center of the service planning and delivery. You will hear, as Peggy just mentioned, about the concept of the golden thread as an image to remind you of the need to link goals, objectives, interventions, and outcomes. So first, before we look at the person-centered planning model, person-centered planning process, I will introduce you to the wellness model. And here's a definition of wellness, and there are others, but here's one that we will offer to you. Wellness is a conscious and deliberate process that requires a person to become aware of and make changes for a more satisfying life. Wellness is self-defined. Each person will have a very personal and individual vision of wellness, and I'm sure you can think in your own life what your individual vision of your own wellness is. Wellness is represented here by the 8 dimensions of wellness, which, as you can see, I hope that you do all have this. We are hoping that you, if you haven't printed this out as a handout, that at some point that you will print this out and kind of keep it handy, because we'll be talking about this as we move along. And the 8 dimensions is an important concept, and you will learn how to use this model to understand a person's goals, preferences, and needs through the person-centered lens. So this is the point here. We're turning the lens and looking through all these particular aspects from the person's point of view. So this graphic shows 8 intersecting circles, and they represent all the dimensions. So you see they're all labeled: the emotional, environmental, intellectual, physical, occupational, spiritual, social, and financial. So these dimensions really encompass most and all, I can't think of any others, of human experience that relate to all of us. This is nothing specific to people using the behavioral health system, but those people have exactly the same strengths, abilities, preferences, and goals as we all do in these different dimensions. So we're gonna, like I said, return to this picture throughout the training because it puts the human experience in terms that we all understand, and help us remember that the goals of the people that we work with will tie back to these particular dimensions. And we want service providers to think of these areas of life as goals that ultimately get established for recovery. So person-centered planning is driven, again, this may sound repetitive, but you know, we all learn by repetition, is driven by the hopes, dreams, aspirations, and wishes of the person receiving the help across all the wellness dimensions. And we'll talk more about why that's important as we go. It is a partnership. The foundation of person-centered planning is a strong and trusting partnership between the person served and the service provider. And we will provide today some examples of partnership and offer some action steps that can move the provider community toward enhanced person-centered care. So person-centered planning. Again, here is a little more elaborate definition. Each person receiving behavioral health services should have an assessment and a service plan that is used to guide the service delivery. I'm sure that's not not unexpected. I'm sure that's how you all are working. An assessment is taking stock of the current situation, and it provides a starting point for the work that is the work of the service plan that we undertake with the person. It's good practice to start with assessing needs and strengths and then plan accordingly, understanding that the plans change as they are implemented. A person-centered approach is used both in assessment and in service plan development. So those two things both need to be looking at person-centeredness. So this includes, for those of you that are using the individualized transition plan that transition coordinators in Louisiana are creating, but we are using this term service plan to include those plans as well as other individual plans that you may be using in your diverse roles. We know that we have a number of you joining us today, and you may all have different types of plans that you're using. So think of service plan as an umbrella term that we're speaking of today. Person-centered planning is collaborative, where people using the services participate in the development of the service goals and in the selection of the services provided to the greatest extent possible. So collaborative means working together as partners. And for some providers, this may be a new way of working with the people that they support. So now we're going to divert a little bit to some of the philosophy aspects of nothing about us without us. That many of you may have heard that phrase. It is the theme really of person-centered planning. Nothing about us without us. It means that the person served should be at the heart of the service planning process. The creation of plans and their implementation will only succeed when the person, the individual, is truly on board with what is going on with the plan, which is probably obvious to you all. But there is an art to creating person-centered plans, and we will explore factors with you leading to successful creation of such a plan. It is a strength-based process. While documentation, and I'll return in a minute here now to the medical part, while documentation of symptoms and clinical concerns is necessary, a strength-based approach gives equal attention to the individual's abilities, preferences, and goals. By looking first for the person's assets rather than their liabilities, you will convey hope for recovery and respect for the person served. People using these services are active participants as opposed to being a passive recipient. They are active participants in choosing their goals and plans for treatments and supports. Significant others need to be included as core participants in the planning whenever an individual desires that kind of involvement or when legal guardianship requires it. So we have now another graphic. This is another piece of paper, another graphic that we hope that you will keep handy with you. You will see how these two pictures basically come together to help bring person-centered planning implementation into focus. So this is a graphic called the 4 Ps of person-centered planning. It is based on 4 core principles. These core principles were originally described by Janice Tondora and her colleagues at Yale University. Someday you might want to Google Janice Tondora and see the many other wonderful works that, that she has available. But these 4 Ps are pretty elegant. The picture reminds us that the work we are doing to assist people in their recovery includes both art and science. It helps us to keep our eyes on the prize, which is another P. We're supposed to smile at that, okay? People want to pursue goals that are meaningful in their lives. They want jobs, they want homes, they want relationships. And we are reminded by this picture to make sure we're tending to those goals as identified by the people we serve. So next, I'm going to describe each of the 4 Ps. As I said, it would be nice if you could keep this picture handy, but at least you'll have it to refer to. We may take a few side trips as we go through these 4 Ps. So the first P is philosophy, and you'll see we've got the arrow there on the slide. It is the sort of the base of our pyramid. It encompasses these concepts, and the concepts are noted there on the slide. The first is hope, which means that service providers convey that recovery happens. And you guys, I'm sure all know this. Many people who use behavioral health services, especially people who've been in the system for a long time, feel discouraged and they feel hopeless. Part of our job is to create an atmosphere of hope for recovery, and not just hope, but a concrete expectation that recovery will occur. Self-determination. Service providers create opportunities for people to make choices about their own lives. We create opportunities for people to have an opportunity to actually be self-directed when they may have not had that opportunity in a while. Meaningful. We focus on aspects of life that are the most important to persons served. All of us are most likely to work with things that we value. And of course, that is very personal. What's meaningful to one person may not be meaningful so much to another. And the other concept is inclusion. Service providers endeavor to support and ensure inclusion with disabilities into the same community opportunities as those that are available to people without disabilities. Anne referenced some of that whenever she spoke to you about the Department of Justice settlement at the beginning of the day. So this philosophy has evolved over time, and I will describe that as we go. The next layer of our triangle is process. We need to think now, we spoke about philosophy, but philosophy has to get moved into action. And so the process of person-centered planning details what happens, who participates, and how the service plan gets made. We will cover that in detail as we proceed. So the next slice of our pyramid is the plan. The plan used in person-centered planning will be described in greater detail in the full training sessions. As I said, we're giving you a distillation today. It's about half as long today as it will be when the full training is offered, which will give people an opportunity to practice some of this stuff. While agencies may use planning forms or electronic health records that look a bit different from one another, and I'm sure this is true in Louisiana as it is in most states, you have different agencies use different plans. All plans typically have the same components, however, which are goals, objectives, and interventions. What makes the person-centered plan different is that the goals are focused on improving functioning and life satisfaction. So typical goal areas are employment, relationships, education, independent housing, and participation in meaningful leisure activities, with any of the 8 dimensions of wellness being the potential focus. So remember, we had the flower a minute ago with all those different dimensions. So the person served will focus on what their particular dimension of wellness is of their choice. So the goal is defined by the person you are supporting and should be written in the person's own words. And this takes a while to get used to doing, but that's how you start. This is very different. Again, we're talking about changing practice. Potentially this might be a change for you. It is different from treatment planning goals that are focused on reducing symptoms and are defined in the service provider's words using clinical language rather than ordinary day-to-day terms. And then we come to the pinnacle, again, another P, which is the purpose. The purpose is to achieve outcomes that are meaningful to the person who owns the plan. This requires a very personalized process that takes into account issues of culture, spirituality, trauma, many other individual factors. So assessments are used to really understand each individual and their family's history, their strengths, their needs, and vision. And service plans and outcomes then can be built on respect for the unique preferences, strengths, and dignity of each person. So here's one of the side trips that I said we were going to take into history. This helps you understand, hopefully will understand, those of you that are perhaps younger or new to the field may not be so aware of the history of how we kind of got here. The 4 concepts of the person-centered planning philosophy, hope, self-determination, meaningful, and inclusion, evolved from lessons learned in the consumer survivor movement, which developed around the same time that the community mental health system originated in the 1960s and 70s. I'm old, I was there. Large numbers of people who were inpatients of public psychiatric hospitals were discharged into the community, and many were discharged, I would say probably most, without the necessary supports. The advent of first-generation antipsychotic medications allowed for these discharges, but rehabilitation and recovery were not really prevalent concepts at the time, Instead, our service systems set goals for individuals such as stability or quote unquote compliance with medication. As the mental health services system evolved from inpatient institutions as the primary point of care to the community mental health center as the sort of center of gravity where treatment was given, people using services were still expected to adhere to what the quote medical professional felt was best for the person based on diagnosis. The consumer survivor movement had many concerns with this, raising issues about oppressive treatments like institutionalization, forced treatment, lack of attention to harmful medication side effects, and lack of choice of community involvement. And as an aside, there are a lot of interesting writings about the history of the consumer survivor movement that I would refer you to if you're younger and haven't been around to learn that history. As time passed, service models shifted, and this is something that we're now actively all involved in. Instead of having care revolve around, quote, centers where people were expected to show up for services and supports, the service locations moved into the community. The concept here was that the individual care and support should go to where the person is. This most often took the form of assertive community treatment service teams, which in Louisiana you have many of, where treatment, when we first started ACT, was called in vivo, meaning in life. So treatment was happening where the people are. Or also in mental health rehabilitation services, which might combine office visits and community-based care. As the system changed, this evolution brought greater understanding, and this is a key point here, that recovery is not only possible, but it is present. So let's turn our attention for a moment to recovery. Again, with the history, recovery concept emerged in the 1980s and 90s and is in contrast to seeking stability, quote unquote, compliance with treatment, and having the primary goal of the community tenure, which suggests that the most important thing was keeping people out of the hospital. I certainly, in my own life, remember very well being taught in the 70s that the best we could hope for was stability and just keeping people, you know, out of the hospital. People did not talk back then very much about recovery. But recovery is often defined as a process or a journey through which people are able to live, work, learn, and participate fully in the communities of their choice. Some experts include reduction or remission of symptoms in the definition, while others emphasize that recovery need not imply a cure or a disappearance of symptoms. Again, this is an evolving and self-defined concept. As part of the consumer survivor movement, people using behavioral health services really became more insistent that it is their right to drive their own services and define recovery for themselves. The value of this point of view of the person in services has evolved to include the role of peer specialist, and Anne mentioned earlier in her presentation about how Louisiana is moving forward with a number of areas around using lived experience, peers with lived experience in various roles, and that is a person who has experienced similar challenges. A peer specialist scope of practice includes leveraging their own experience to support and guide the recovery of others. It is a very big addition to the mental health field in the last number of years. It's a whole new scope of practice. So the evidence for recovery. I spoke a moment ago about how recovery actually can happen and that it's present. And we need to be remembering it ourselves. We certainly need to convey it to those we serve. The evidence of the existence for recovery emerged in a 1987 landmark study by Courtney Harding, showing that a high proportion of the people discharged from State Hospital in Vermont went on to have full and satisfying lives, even after long periods of hospitalization. And I personally remember being at the big community support conference where she presented those findings, and people were pretty thunderstruck. After the Harding study, more evidence emerged that recovery happens. While specific results vary across studies, researchers consistently find that most people with serious psychiatric conditions do get better over time. Documented rates of recovery range from 48 to 77%. And when the right services are provided early, complete remission of psychosis can occur in 70 to 90% of people served. So this is a very important thing to think about with young people, the notion of starting early. And I know that you guys, as many states are very much interested in making sure that we work with young people as soon as possible. That being said, there's no doubt that supportive and person-centered care will enhance the likelihood of recovery, and integrating person-centered approaches will lead to better outcomes. The consequences of mental illness certainly include poverty, discrimination, unemployment, poor housing, and all these factors are things that providers address. I think I saw a flash in the chat box, somebody mentioning that with COVID, it is a huge challenge. And I suppose I should have mentioned that at the beginning whenever I was speaking about ACT or any of these other services where you're going out to the world to people. It is certainly true that people are having to alter their practice, and people are attempting to use Zoom, using phones, using various other ways. And there's nothing, it is sad. It is sad that this pandemic has created this happening. On the other hand, we've heard about a whole lot of creative people and creative ways to maintain connections with individuals. And in fact, I've heard anecdotal reports that some persons served kind of are enjoying this, a different style of being assisted. So we'll see how this all turns out. Hopefully soon we'll be able to return, excuse me, to our regular, in vivo care as much as we can. Okay, let's take a look here at the benefits of person-centered planning. Some of the research evidence supports the idea that person-centered care yields better outcomes. We do have a reference list for you. I think it's at the end of this presentation, or if not, we can get it to you, that describes those findings. Consensus between the person served and the staff person regarding goals and plans is well supported as a contributor to positive outcomes. That just makes sense from a human nature point of view. Plans that are created in partnership, and this is important here, reduce confusion and misunderstanding about the wishes and the abilities of the person served and the services provided. So what you want is to make sure that these plans are written into regular talk so that anyone reading it can understand who is responsible for doing what and by when, and providing direction and accountability. We'll go into a little detail more later about how to create more effective plans that indicate that the person served is actively engaged in the process and making decisions about the plan and has their own responsibilities for enacting parts of these plans. So support for person-centered planning. On the slide there, you see a couple different places or references. In 2001, the SAMHSA, which is the Substance Abuse and Mental Health Services Administration, identified a set of evidence-based practices for behavioral health, and based on findings that those practices create better outcomes in treatment as usual. Evidence-based practice is, there are a number of them. As you see, there's 4 listed. Assertive community treatment is one that is widely used in Louisiana, and other practices like integrated dual disorder treatment, supported employment, which I'll be talking about more in my next session, and illness management and recovery. All 4 of these practices have the core, at their core, being person-centered. The Institute of, I think I skipped that part about the Institute of Medicine, but anyway, they also it was also adopted by the Institute of Medicine as a central philosophy and practice for all medical care, including behavioral health care. Sorry about that little glitch there. Okay, now we're going to get back on track with our process. So the second P, remember we went through the pyramid. Now that you have some background on the topic, let's look at the other P's of person-centered planning, starting with process. So in order to implement a plan, we have to consider how to plan for the meetings, what will happen during the meeting, and how to move forward after the meeting. This may or may not be a change for you folks. The person should invite important people in their lives into the person-centered planning process. The step is at their discretion and may represent a change for you. Like I said, having others involved who can support the person in their plan is a big asset. And the provider will gain important information about the social and family circumstances of the person that you're serving. Privacy is key, and appropriate releases, of course, will be needed. It's possible that the provider may have issues with somebody that the person served wants to bring into the planning process, and that will provide you with another area of fruitful discussion to understand the person better. So the provider will explain the purpose of a plan. This kind of approach really might be new to the person you're serving. I know that in the past, people would have their plans sort of given to them, and that the plans would be sort of cookie cutter, and they would all start with take your prescribed medication, show up for your therapy meetings, whatever. This is a different style. So helping the person served understand what their partnership responsibilities are in the plan can be new. I mentioned this before, but it will bear repeating. The language in the plan should reflect the words of the person served and should be written in language that makes sense to the person and should reflect their issues and concerns. And this is where the art comes in for the provider. It is the provider's job to translate that language into medical necessity when it is required. A tiny example might be the person says, I want to quit fighting with my mom. The provider might add an explanation to that statement, such as Mr. Jones will learn to de-escalate his reactions to his mother's criticisms by managing his stress. So we have to be the translator, the bridge, and we'll talk more about medical necessity later. And the person should endorse the plan, sign it to confirm that endorsement, and receive a copy of the plan and have regular opportunities to revise the plan. These plans are living, breathing documents, just like everything in all of our lives. Things change. So the third P, the plan includes, as I said before, and you all know, goals, objectives, and interventions. These are familiar. The key to making the person-centered planning work is to break it into smaller steps. So the goals need to be clearly stated in a way that is relevant for the person. The goals could be very large, like get a job, stay out of the hospital, get an apartment, go to school, make friends, take care of my health. You guys can dream up many others. The objectives, however, need to detail the accomplishments that will move the person closer to the goal achievement. This is where the large goal is broken into bite-sized, manageable parts. The interventions detail how each objective will be achieved. Each intervention statement needs to be clear about who does what, answering the questions, what does the provider do, and what does the person served do? The process also includes a discussion at the next meeting of how the intervention went. Remember, the intervention is what the provider is doing. So, your choice of language is very important. It needs to reflect a person-centered and collaborative process. Another way to think about this is that treatment, as we understand it, is a focus on achieving and maintaining clinical stability, addressing symptoms and illness as defined by the service provider and the provider's clinical language. For example, and I bet you've all heard this, participant will experience a reduction in auditory hallucinations and other psychotic symptoms. In contrast, person-centered life goals focus on improved functioning. As I've mentioned before, this is now starting to sound repetitive: employment, education, independent housing, developing and maintaining relationships, etc., which are defined by the person and in the person's own words. So example is, I want a job as an office manager. Now, bringing these things together, certainly getting to the person's job goals in this example might very well include managing the symptoms of a mental illness if those symptoms are barriers to the goal. I hope that you see what we mean by the difference there. If the person agrees that symptom management is a priority objective in order to get to the goal that they have stated, the plan will indicate that and will include both interventions to be delivered by service providers and steps to be taken by the person served. So we are not saying that symptoms are not important. What we are saying is the important thing is for the person to know what it is that they want to do, and if the symptoms are getting in the way, that's the reason we care about the symptoms. The interventions and the person's actions all need to clearly link back to the goal and must be documented over time to show whether, in fact, they are moving the person closer to their goal. The service provider is responsible for documenting how well the plan is working and how it meets medical necessity. I saw a chat question there, but it went by too fast. So I'm gonna pass by there, and I trust somebody will tell me if I missed something important. So now we're gonna talk just again a minute about the golden thread. I have to assume that you folks are familiar with that phrase, the golden thread. But if not, I'm going to give you a small tutorial on that. The so-called golden thread documents how person-centered planning components are connected to one another. It is the through line from intake, where qualifying diagnosis and functional limitations are identified, to the eligible services that are reimbursable. The plan may also include natural supports and other elements that are not directly reimbursable. So documentation, most likely everywhere, must include diagnosis, the disability, the functional limitations that are establishing that the person has the qualifying diagnosis, and describing how their functional needs can be remediated by the eligible services, right? That's the link. The person has a condition that is eligible for the services that are being provided. They have functional needs, and that our services can assist with them. And these are included in the assessment and the plan, along with assessed needs, risk factors. And then here's what is often not happening, but what we want to have happen is that the person's wellness vision and goal statements appear in this documentation. The objectives that name the target outcomes, indicating progress toward achieving that goal, and the person's expressed preferences for services. And that the interventions are designed to achieve each objective. That is to say, what will the provider do? Progress notes documenting the delivery of each intervention, how did the person served respond, and what alterations in the plan are needed in that experience. So the golden thread always reflects the reasons why things are on the service plan and how they relate to the medical necessity standards, okay? Why are things on the plan? How do they relate to medical necessity? The service provider must make sure to appropriately convey this. This again is your art. This is a succinct, although I will say academic, definition of medical necessity. Quote, medically necessary services are defined as those healthcare services that are in accordance with generally accepted evidence-based medical standards. Necessary service must be deemed medically, I'm seeing Peggy saying we got to move along here. Okay. In order to be considered medically necessary, services must be deemed reasonably necessary to diagnose, correct, cure, and alleviate or prevent the worsening of a condition, etc. So you can read that definition for yourself. So we're moving to the fourth P, purpose. And this fourth P is the pinnacle of the pyramid for a reason. The partnership between the person served and service providers should result in clear and meaningful goals, plans, and services that lead to recovery and wellness. Always remember that the purpose of the process and the plan, all of that stuff, is to help the person move toward recovery and wellness by achieving goals that are personally meaningful. And now Peggy will take over.
So thanks. So we're at a point where we want to have a little bit of, we would want to reference some questions that may have come up, and we also want to have a chat. In the chat, we'd like for you, we'll take some questions, we'll take a little bit of time for that, but before we move into the next phase, we'd like to hear from you how you see the wellness dimensions could help you think about for your own goals or the goals of the people you serve. So think about your own goals or the goals of people you serve. How do you see the wellness model, the 8-dimensional model that Virginia went through, being helping us in terms of thinking about our own goals? So we want to hear that in the chat. Like before we move into the next piece, we want you to start to get your thinking around how to physical, spiritual, social, intellectual, occupational, environmental, financial, these different areas. How do you see this fit? So let's see what comes up in the chat. Is everyone able to see the chat and post in there?
Just as a reminder to everyone, if you can use the chat on your desktop through the Zoom link, that would be ideal. I am also trying to monitor the chat that's coming through the app on the phones, but it is much more effective to have questions come through.
Okay. So are there anybody able to share how the 8 dimensions could help you think about your own wellness goals or the wellness goals of the people you serve? What's your thinking on that? We want to get a little pulse here, what you guys are thinking so far from what Virginia's talked about in terms of the 8-dimensional model and how it's, and just how do we, because it's really about this goal setting, this person-centered planning goes to goals, but think about your own goals or the goals of the people you serve. I'd like to hear.
Peggy, this is Anne. I'm not seeing any chat come through either on the app or the desktop. There was a question earlier that somebody asked that may be somewhat pertinent to the question that you're asking today.
Yeah.
And I'm wondering if it would be okay for me to go ahead and read that for you.
Sure. Yeah. We want to hear, kind of get the pulse of where, so we respond.
Yeah. So a question was asked, how does one deal with goals that people have set that are not necessarily realistic or achievable?
Well, you know, I think that's really where we boil it back to the philosophy and start to think about, rethink our philosophy, use that, you know, go back to the foundational piece Virginia mentioned and rethink what is not realistic or not. And when we start to think that way, how can we dial it back and re-engage with the person to kind of think through, you know, I want a PhD, which I had that as a goal, like at one point, and many people said to me, you haven't even barely got out of community college. How can you have a PhD with that being in community college, barely getting out of it? And then, you know, eventually you get a PhD many years later. So thinking through, you know, basically not necessarily assuming that it's a realistic goal, but having a dialogue with the person and really getting back to what this is about. What is this purpose of this goal that might seem attainable to us? And then really bringing it back to understanding where the person is now and understanding that maybe not to, that's a deferred goal or something the person's going to look at, but not to squash that goal, but to really reassess the person's strengths, the challenges, the barriers, and then help the person to work where they're at this point, you know. And that's the way if we use the person-centered planning process, you can really help a person to, you know, think big, but start to think where you're at now and then started moving forward in their life. So that's just one thing I would think about, because I've seen so many people have large goals that people have shut down or have felt they were unrealistic, and people have been able to accomplish, or people have been able to go through a process when someone supported them to move through a process that perhaps maybe they went on a different path, but they understood what was the meaning behind that goal and you know, the connection to that goal for a person. And then once we understand that, we can help people with what's where they're at now. Virginia, do you want to add anything to that?
Sorry, I was muted. I would add only that sometimes it's good to find out what have the person talk more about what their goal is and what about that goal is attractive to them. Sometimes it just takes getting to know more from the person about what's really behind it. You know, if someone says they want to be or they name an employment goal that seems like wildly unable to be reached. But like Peggy says, the person wants to be a plastic surgeon, but yet they haven't gotten out of grade school or, you know, high school. You might ask, what about being a plastic surgeon is appealing to you? And what do you think we might have to work on first before you can get there, as opposed to saying, are you kidding? You're never going to be a plastic surgeon. It's honoring the person's wish and trying to get behind the stated thing to get into the contents, the real contents of what it is that they're after is one way to think about it.
Are there any other questions or anything you wanted to add to that, and or anyone else has put into the chat? Okay, well, if not, we're going to continue to go. We want you to be thinking about how do you use this wellness lens in the person-centered planning process to kind of help the person frame their goal, especially focusing on the strengths, because I think that's one of the things that often gets overlooked or doesn't get looked at. And we think about the 8 dimensions guiding us to kind of help where the person's important. And we've used this a lot as a tool when we're working with people in person-centered planning, is that they use this image even to help people to think about things that are even meaningful. And just from that, people in recovery or people are like, wow, it's positive. It really helps them see more than just mental health or addiction or these chronic things that people are telling me, these symptom focus. This really helps us. It focuses a lot. You can see on the physical area too, which we do know is so important for so many people with comorbidities. But the whole wellness wheel really brings a lens to help us think about the assessment process, because we want to look at a strengths-based, function-based assessment. And so when we think about that strength-based assessment, we want to look at what's the priorities of the person, what are they doing now for the wellness and recovery? And that really is an important piece. Like, what are you doing now? And a lot of times I sit with people, what are you doing physically, spiritually, socially, emotionally? People are doing things. So it helps get a current assessment of what are some of the skills and the assets they have. And we can really get a good picture when we use the framework of what is going on. And then what do you need to do? What are you doing? What do you have to do? What can you do? And that really helps. A lot of times that function focus really becomes a big piece. Those, and especially things that we work with people on: sleep, activities of daily living, instrumental activities of daily living, school and work. And I think a lot of the work in the transition planning becomes that habits and routines, activities of daily living, as well as the instrumental activities of daily living that people need in terms of that function. With the strengths, they really can be a foundation for the plan. I think sometimes there's like 2 or 3 strengths in a plan, and I'm just like, oh my God, really? Have you talked to that person? Because when I talk to people, I get like pages of their strengths, especially when I use the wellness wheel with them. And they really provide the foundation for the plan, helps to see what are the habits and routines and the skills the person has. Other kinds of strengths that you can look at are the people, places, things that are available to people, and just finding out what do they see as support. And then there's the resources, those things that are personal resources the person has, or the things that are available in the community. So strengths is a really important piece to think about in this process, and remembering to just not have 2 or 3 strengths on a plan. And but with the assessment process, we want to think about being different than a diagnostic assessment, because we're focusing on the person's, what do you want for a better life, or what do you want for your wellness? And when you talk to people about that, you get a lot of different reactions and different things that people say that will be important. And it's just getting that vision of the person, what the person focuses on, what they want. What do they want? What do they see their strengths as? What do they see the challenges and barriers? And what do they see as their needs? Really assessing that in that person-centered planning process of what is their perception. You may not agree. You may seem to think that it has a little delusional or symptom is impacting, but it's important to kind of understand where that person's at. And really then also what is the priority needs. That really becomes the big piece of it, is to think about what is important for the person. And we can think about things that lead to success in terms of the social dimension, being a sense of connection and belonging, as well as a well-developed support system. How people see that definition of social dimension might be different from person to person, but a lot of time, and we can think about, say, for example, an extrovert person may want a large circle of friends for many social events. So that might be there. So not everyone wants to get this large group. For someone who may be introverted, it may just be like one or two close friends. So it's going to be individualized to the person, but the same thing is they're going to focus on a social dimension of having a connection to someone. I think that sometimes we get into these cookie cutter goals around different areas and we forget that people have different personality styles, different preferences. So those are just something to think about. But regardless of how the person defines it, it's just really looking at questions and kind of really helping the person to think about and understand these areas for themselves and figuring out what would be important for them in terms of what they think. We can also think in terms of function. You know, a lot of times you'll see in goals in terms of the financial dimension is money management being an area. So looking at you know, for this money management, we see that as the goal, but you want to think about helping the person to break it down into things, making change, paying, creating a budget, helping people to manage budget. People say, well, you know, people are poor, they really don't have this. But I think that we forget that people can save, can learn to budget, can learn to try to stay away from predatory lenders. That's a big issue with a lot of people. I see that a lot with people I work with, to stay away from the predatory lenders that come about, or refusing requests for monies from other peers. You know, these are some skills that you may need to be thinking about with people to try to help them, and then helping people to build that financial wellness area that people maybe not going to develop a lot of wealth and assets right away, but they're going to gain control. And we have a whole bunch of curriculum on financial wellness areas that, if you're interested in more information, where we really helped people just with the basics of budgeting and some basic savings, and it really transforms people's life. But it's important that go where that person is, and you may not have realized it without having a conversation with that person. The strength, in terms of the strength process, the person directs that process. And it's the strengths that should be the focus rather than just the problems or the deficits. And remember, we want to have the person being that director of this. And what happens in this part of the process in terms of the 4P stages is that you use a lot of good communication skills. This is really where those listening is. And I think, as Virginia mentioned, like really explore what that supposedly goal that seems out of a person's reach is, really using some good open-ended questions and reflective listening and affirmations to try to engage in a conversation with the person to really understand the essence of why that person is wanting to focus on those goals. In terms of the barriers and challenges, so we do look at that because we need the whole picture. What are your strengths, but what are your barriers and challenges? These are important, especially as it's into relationship to the goal or the area that the person's identifying as a priority area. Again, thinking about the function of that the person's talking about. And we will also see that the barriers will often be related to the golden thread, you know, that indicates the medical necessity. So thinking about that in terms of areas, but also things like social anxiety, trauma history, or other things can also be barriers and challenges that we want to be looking at as well, and thinking about that in terms of when we're helping a person. A big area that is important, again, we're saying with the COVID, it may not be face-to-face, but a location that can be chosen by the person or that's accessible by the person is important. Inviting others is important, to have a person have their supporters, and then you're already doing some role modeling for supporting. And really build the core of the plan in the meeting, using the, you know, this process, exploring doing the assessments, doing the strength focus, looking at the barriers, being able to do it, but then really bring it into everyday language. Sometimes people have to tweak their forms a lot. I'm really big tweaker of forms, especially when people have different types of literacy issues. It'd be amazing how engaged you can get people when you make the form or you make the process kind of colorful or have visuals with people, that it will really build people into it a little bit more. Using that living room language and avoiding the professional jargon can be important, because I can tell you a lot of people will tell me that they just didn't even know what happened and they just went along. Giving the person a copy of the plan is really important, and it may not happen in one sitting, so remember that too. Moving on to goals. The goals is defined by the person, as we mentioned, and the goal captures the fourth P, which is the purpose. Trying to find out what's an outcome that's meaningful to the person who's going to really own this plan. This self-determination is also a piece to think about here, which means respecting the right for the person to make that decision that affects their life. And that's just also a really important thing. Using the person's words. I know even with Joint Commission, I don't know if people are following those kind of regulations. That is a regulation that's looked closely at Joint Commission, and I know that's a hot one on Joint Commission's radar these days, because often, many times in behavioral health, we don't use people's own words. And again, we consider the 8 dimensions can be really, really important in terms of the way goals are written. In terms of goal statements, I often can look at a chart and doing a lot of work with treatment planning and looking at things for years and years, but I can also recognize a provider-centered goal by the language that use. And you see a lot more things around medication compliance, reductions of symptoms, stuff related to behaviors, preventing decompensation, achieving stability. People usually don't put that as their goal. And that's really where we have to come in and talk to people about how, we want people to have, not to decompensate. We want people to be stable, but it's in the service of something else. And that's really where the dialogue comes in. And when we write this goal statement, let's get to the heart of what that person wants, rather than diverting to those jargon that we often use. Those are problematic areas for many people. Things like, for example, the person wants to find a church or another spiritual community to go to, thinking about those kind of person-centered goals. Things about reconnecting with their family or children. Things like cutting down or quitting smoking. They can be really concrete goals that are SMART. And many of you may know the acronym of SMART, being specific, measurable, action-oriented, realistic, and time limited. So thinking about a SMART goal, that gives us a mnemonic to kind of think about it and have a dialogue with the person too, because when we have a SMART goal, it's something we know, okay, you're not doing this now and you're going to be doing this. It really helps to provide a target, and it provides a measurement for something we can, the person can accomplish. In terms of the goal setting process, we want to explore their visions and strengths and what their desired change or desired improvements. I even found, working with people, just the language of, what do you want to change, or what do you want to improve, or what do you want to strengthen? It makes a big difference to people, rather than what problems you want to solve. We can do problem solving, or you have all these problems, but when we say, what do you want to strengthen? Often provides that also low-hanging fruit kind of thing, because you're going to make something stronger, and translating that into a goal can be very appealing for people. Using the person's own words. And the other piece of it, it goes back to that priority, is to ensure the commitment of the person. And that really is going to come from like a dialogue and really being able to get a holistic view of the person. During the process, we may assume people that people do, we're assuming they have goals, but sometimes people don't want to have goals, or they're feeling overwhelmed by goals. And often this can be many reasons, and this is really, again, where your connection and meeting with people and developing that trust. You want to understand about this, because people may have had a lot of losses or a lot of defeats in their life, so they don't want to set yet another goal. So just remembering that lack of expression of a goal or engagement in a goal can be, be part of that. They've been feeling demoralized. They may feel hopeless. They may not have that trust of you. So again, it goes back to the relationships and how we organize the meetings, and we create that trusting relationship and that fear of taking risks. So that's just another barrier that potentially could get in the way in terms of the goals. In terms of the objectives, they become what we call the accomplishments on the journey to the goal. So they become these measurable outcomes that can really show progress. So they really help when you have your goal that you create and you've looked at the assessment, the objectives become those smaller and shorter statements that I think sometimes I find that these actually become the roadmap sometimes for the person to be able to accomplish what they can do. And I think getting really good objective statements that we work collaboratively with people on help create that roadmap that helps the person to their success. In my many, many years as an occupational therapist, we do this for many people in many kind of function in mental health and physical health. And they really becomes the roadmap when you concretize the goals into these objectives, and it makes it really easy for the person to accomplish the what they're hoping to, and then it helps you to provide that support and the form of the interventions that we provide. And maybe really sure, again, making sure it's what the person wants to do or what is the target, and using action verbs is really important. And that measurement of performance can be really important in putting together objective statements. Related to that are the interventions. So this is really where we come into the idea of what you are going to do to help the person to achieve the objective. So what are the providers going to do, or what are the other kind of supports that are going to happen that's going to help the person be successful for accomplishing this goal. So it becomes like a recipe and a piece. And to be really successful, it's really important to have those interventions that really are there. What are you going to do to help that person? Could be teaching them, help them practice. You can do some role playing with people, educating, coaching, developing skills, in providing certain types of evidence-based education to them. These are the kind of interventions that might be important depending on the person's goal that you'd be helping the person with. In terms of implementing the person-centered plan, there's different strategies and structures and roles, as I mentioned. So the strategies, the way you're going to engage, the aspects of the environment that's going to support it, the structures, and then the roles that you might have. And again, the different team members, now we see peer support roles coming in, case management roles, nursing roles, psychiatry roles. Everybody has a role, so everybody can be part of this plan to help support this person accomplish what they're hoping to accomplish. And in terms of the plan, again, it becomes that recipe there. The plan is the type of the intervention. It's going to be provided by you or the other entities that are involved, including how often it will be provided. And sometimes it may even include like how long the session is or the other kind of delivery of it. What is the modality of it, being group or individual, providing who that person's going to be to deliver that, where it's going to happen, and when. And this becomes the recipe for success when we can provide those kinds of details that are going to be outlined to try to help that person to be successful. So thinking about it, Virginia's big on making pies, so we thought we'd add in a recipe analogy to this process. For example, the type of interventions, people with the goals of independent living maybe need things in terms of the money management, the financial dimension, keeping a clean and safe living environment, the environmental dimension, and just keeping themselves well, maybe the physical dimension, some of the self-care things that the person needs to be able to be successful in managing themselves, those activities of daily living that could be important for them. In terms of the types skill development, this is a big area that I think often gets lost a lot of times in the area about the teaching of skills. And a big area that I think goes a long way and then can help people to be successful. So teaching how to do the skill, teaching what it is, how to do it, when to use it, the skill building things in terms of psychiatric rehabilitation, skill building, peer support can do a lot around this. That can be a really important area, and then helping them to coach the person to continue to use that. This is done, there's a lot of good work been done in this area in terms of skill development, and we encourage you to kind of be thinking about building that more in to help people to be successful. There's an approach called, in terms of skill development, called the tell, show, and do. So it's that telling, explaining the what, why, how, and when of the skill, demonstrating the skill or having the person demonstrate the skill, and then arranging practice opportunities, because that's what happens. We learn things and we develop habits and routines and we develop new skills by practice, but we need to learn them. We need that knowledge. We need to understand the information. We need to practice doing it. We need to see others doing it successfully, or the performance being shown to us. And that's just a little bit of a acronym that we would thought you want to think about in terms of doing the interventions and teaching, is the tell, show, do. Another part of the planning process that often becomes challenging often, but can be so important for helping people be successful, is the feedback that we give to people on the plan. And that, you know, might be intervals where you do that feedback time. But that's really important, especially when there's like not progress on it. That's a time to sit back and readjust this plan, or reevaluate it, or reevaluate strengths and needs that are maybe changed or evolved. Or, but the feedback on celebrating the efforts and accomplishment, regardless of whether there's things have been accomplished, but just sit back and doing it. And what we do a lot of times in this process is having the person see, like sitting down and think, how do you think you're doing? How is this going? How is this going for what you did in your role? And having the person answer that. And the providers, the same thing, the interventions you were to do, how do you think we're doing? And then use the praise, polish, praise format, where we give feedback, like giving the acknowledgement of the strengths and the things that have gone well, offering some polish, and then sandwiching it with some praise or some recognition of accomplishments. And we find that and focus on actions and efforts, not characteristics, because we want to be concretized on the plan, is important. And that really can have been very helpful in terms of giving feedback to people that's really concrete, relates to the plan, and that full acknowledgement of what's gone well, what can be tweaked, what could be polished, what might need to be rehashed or revised. Those are all realities, but having that feedback and everybody taking the feedback is a good role modeling process, and a good way to help gauge where you are and where you want to move to. Communication is really, and engagement is important from all of this in terms of person-centered planning. And again, the person being the driver is really important for this, but don't like just give it to them and not help them navigate the route. We have to know they're the driver, but if they're learning how to drive, we're going to help them learn some of those skills and help navigate that route. And we're going to help them in learning more of the skills they need to be independent in this process. But we need to really remember that communicating, engaging, and collaborating is really a big piece of this. And we all have a role, but we do want to respect what the person's vision is, what they're saying their purpose is, and recognizing their strengths and their aspirations that they have. Team communication often, and that can be challenged by, you know, turnover and things like that once the thing's moving along. But team involvement is important, understanding who's on the team, making sure everyone knows who they are, one another are, and the role, and keeping people informed. There's usually someone who's helping with that. Very important for success of the person-centered planning process. And again, helping to seek the clarification that's needed in terms of basically from each other, and keeping up to date with things is very important. In some situation, it might be a guardian role too. So that's an important person too, because sometimes those guardian situations can be a little tricky as well. So making sure that person is there and that being part of that communication loop will be very important. I'm going to return it back to Virginia now.
Hi, I'm back. I think we're talking about orienting now, which is another way of saying what we all know is, orientation is figuring out what's going on. We want to make sure that we're informing the person that we're working with about what's going to happen and make sure that they're interested in participating. They may be more or less interested depending on your relationship and depending on their circumstances. And so this will always include reminding you and them about the goals and objectives and making sure that they continue to be feeling like the goal that was stated is the goal they're still interested in. We have to return periodically to make sure that we're still all on the same page. Also, we use the term intervention, and we've talked a lot about those. That I think the word goal is probably more self-explanatory in language at large, but the word intervention may not be familiar to somebody that you're working with. So describing to them what that means. What is it? How's it going to happen? How long will you work together? How often will you meet? And helping them understand how what this so-called intervention that you're doing is going to help them meet their goal. And be reviewing about how those three pieces fit together. So in engaging the person, these are ways to ensure that engagement begins and continues, that you really want the active participation of the person you're working with. So it really requires our attitude as a provider to be encouraging and positive, to support and sustain the person's motivation. You're loaning your motivation, you're loaning your enthusiasm to people who have been, in many cases, very demoralized by poverty, life, sickness, whatever. And so you can be that motivating lifter. You can lift these people that you're helping by supporting their motivation. And when the person's already been involved in person-centered planning, it makes it easier for them to continue to see this as a lifting up process for them. On the other hand, most of us know from personal experience that we may start out motivated to work on something, and then we lose our focus or our interest, or life changes, or we have a pandemic, things occur. And so if you've got this creative and good relationship with the people you're working with, then you can be supportively using your communication skills to work with them around any changes that need to be made. And remembering your own skills and learning to use your communication skills to listen, to explore the person's thoughts and feelings, to be using as many open-ended questions as possible, avoiding the yes, no, trying to get people to say more, having door opener kinds of conversations with people and phrases. Building on the strengths by reminding them of past accomplishments, current habits, and things that you observe that are going well. This is part of building your relationship, especially when people feel demoralized. They can't think of a single strength maybe. And as Peggy mentioned earlier on, there are lots of strengths. Anybody that survived for any length of time having to be in the mental health system and be in having all the challenges that brings to bear has demonstrated some certain tenacity that you can praise people for and help them see their personal characteristics that have brought them this far and things they can build on. And of course, celebrating progress by acknowledging accomplishment. So, a cup of coffee, a walk, a card, time spent together when you can to help people celebrate the accomplishments that they've made. Okay, Peggy's going to take us down another moment with the 8 dimensions.
So we just encourage you to take a look, and as we kind of wind down and move into some questions and comments and just reflections on how this person-centered planning process works, the 4 Ps of person-centered planning, keep in mind the dimensions to use that as a good lens and a good focus. And keeping this visual, we put it into a handout format for you that you can access. And there's a great video. It's a really short video. We encourage you to listen to it if you're really to just really understand like many of the things we talked about. But it's a nice succinct video that has been done by the folks up over at Yale and their colleagues that have developed this model. So keep these handy, and I love to hear about how you might use them in your person-centered planning processes in your work.
there's a few takeaway messages that we offer you, and I want to endorse what Peggy just said about that video. It's really worth watching, and would be even a good thing to watch with others, you know, wherever you're working, to sort of put a context around all this. But so, you know, essentially, these are our takeaway messages, that person-centered planning is basically a very sensible and participatory style of working with people. The 8 dimensions, the 4 Ps, those things bring to life the notion of making a person-centered plan to be real. And remember that as providers, it is your responsibility for translating the work when necessary into the medically necessary golden thread talk. And of course, people, all people participate in things that are meaningful to them, and that's the same for all of us. There is also a selfish reason, if I can put quotes around selfish, why it is good for providers as well as person served to be using a person-centered style, because people get better, and it is enthusiasm generating for the helping side of this equation. When you see people moving on and being and experiencing recovery and experiencing the goals that you've helped them do, it's sort of the very essence of it's like a burnout prevention thing. You know, whenever you're working participatorily with a person who you've worked with and they are figuring out these things that are important to them, and you're able to help them, you know, leverage their skills, their strengths to overcome some of the symptoms and deficits that they've experienced, it is enlivening and causes enthusiasm all the way around. So I believe we are done with our planned talk. I think there is a moment or two. I think we do have a couple moments if people want to say things, chat, bring things up.
So there is approximately 8 minutes left in the presentation today. There's no questions currently in the chat. You can feel free to go ahead and submit some. I will go ahead and say that there were some items that came through the chat once we had that enabled. For the most part, a lot of them were comments about person-centered planning and models being wonderful. Individuals talking about their utilization of the wellness dimensions to facilitate person-centered thinking. One individual did make a comment, and I didn't know if you guys wanted to speak to it. They'd indicated that they typically provide treatment to children, and that it seemed like that was a different model, that this might not apply to that. Do you guys want to speak to that at all?
Yeah, I think I think there's different, there's some slight differences in some of the flow of it, but I do believe that there's a lot of really great models, and right off the top of my head, it's not coming to mind, but particularly in the, I know working with children who have some, you know, Asperger's and autism and things like that, as an OT, knowing that work, they've used I forget the name of it, but there's a very strong, now the family's very involved. It's a family centered too. So the family's at a core center of the, you know, the individual and family, but a lot of it works very well. And especially with families, you know, because they're the ones who need to, like, they're on the front line, right? Usually. So the more they're engaged and involved, they've seen some really good success. So this was, I think, much more with the work with the Yale was much more adults, but I do believe there are models, and maybe we can get some information for you to be able to look at how some of the slight differences that might be there, or some models that would fit better.
Well said.
Are there any other, I'm seeing still some comments saying this brings so much dignity to the person, and that it's this process makes counseling and therapy seem more normal and healthy, right? Are there any other questions that individuals have? I'll go ahead and ask some other direct questions that people had asked. My apologies in advance if this has already gone over, but I just want to make sure that we are covering everything in the last 5 minutes that we have. How is this different than creating short-term and long-term treatment plans and individual counseling?
Well, I think this is Virginia. I would say that aspects of everything we went through can be short-term or long-term. That's when you get to the objectives. You can have, for example, I am doing this walking challenge, a Zoom walking challenge, where I'm supposed to walk 120 miles in 3 months. So what I've done more than half of it now, not 3 months, 2 months and a few days. So what we're doing is then breaking that down into how much do I have to walk in a week? How much do I have to walk in a day, so that I don't have to walk 100 miles in the last 3 days? You know, those are short term. I have a long-term objective of doing that 120 miles. The short term is now, at the remainder of the time, I have to put in 1.5 miles, you know, for the rest of the time to get it done. I mean, that's a pretty basic example. But I think it also has to do with the purpose and what you're working with someone on. If your goal, if you're only supposed to be with the person for a short time, maybe you're only working with them on one thing, then you adjust accordingly. But whether it's short or long term, if the person is at the heart of it, if the person is choosing what it is that they want to do, and your goal is to help create an intervention that will get them there, it doesn't matter if it's short or long term, I would think. Peggy, I don't know what you have to say about that.
Yeah, I think it's just, it depends, like if it's individual counseling with just an individual, you know, depends on, I guess it's contextual. I think that this model works really well in terms of, you know, for a lot of different types of treatment planning or service planning processes, especially when there's multiple entities involved or partnerships. So I think that that's one of the things that might be somewhat different, but it sounds like it's probably, I'm not sure where the context of where the person's working at, but it is very similar. I think that a lot of times, and it's interesting when Virginia and I were putting this together, there's so much language around goals and objectives and short-term and long-term. So sometimes that stuff kind of gets we get lost in some of that. So it's probably very similar. I'd have to see what the context of that setting is and what kind of potentially processes they have. But it may be probably similar in a lot of ways, I think.
The notion of working.
Question. Go ahead.
No, go ahead, Ann. No, you go, and then there's time.
I was going to say there's one other question. We have 3 more minutes left of this session. Do you want to finish your thought? Maybe we can go to this and briefly address this next question and wrap it up.
My thought was simply that whenever there are multiple people working, multiple different teams, maybe working with the person served under different aspects, that's one of the values of having a person-centered plan. The person should be able to tell you what their plan is, whether or not you can get the other person in the other agency on the phone. If the person is really engaged in making their plans, it really helps avoid the silos and the miscommunications across service entities, was my thought.
Let me read the last question briefly. Good afternoon. With the importance of building a relationship, how do you build that relationship when the person served shows no interest in trying to build a relationship?
Patience would be one thing. And what we know from our work, and Peggy, you have thoughts about this, about motivational interviewing, is directing. We always want to start with where the person is and make your intervention match the stage of change of the person. So a person who has no interest, then you got to find out what else their interest might be. Yeah, it requires also, I think, being patient, and as service providers, we get our feelings hurt. We think we're really going to try to help somebody, and they're like, get away from me, I'm not interested. Well, take a deep breath and come at it at a different angle. It can be frustrating, but I think maybe the person wants an apple, or maybe the person wants a magazine. Maybe the person needs something else from you that doesn't relate to this particular task until you do build a relationship.
Yeah, and I found in my work in many years, sometimes it's just making little orienting the person very, trying to orient the person very succinctly, but then sometimes it's that consistent going back, that invitation, that invitation. I found that when I was working in institutions for many years, that invitation to someone, you want to join our group? No, and then eventually what's that group, you know, and then eventually they're sitting in your group, you know, and it was just but it was a regular smile. I just found myself just constantly just invite people in a way, and then move, you know, if they don't, but eventually sometimes people need to feel it out enough themselves. And eventually they're more than likely going to want to engage because you have something useful for them and you care about them. And when you show that and convey that to them, often they, you know, after they've gotten through whatever going through their mind or their heart or their life, they may just, you know, test it out and then start to develop that trust with you.
Thank you so much. What a great way to end the session today. Thank you all for your participation. Remember, the next session is employment as a social determinant of health with Dr. Selleck, and that is going to begin at 12:45 today. And also just keep your eyes open because, again, as I had said earlier, this presentation today is really derived from a training that Virginia and Peggy had developed, and it is our plan to roll this out in its entirety through our system. And so we're still figuring out the ways in which we're going to be doing that specifically, but there should be more to come on this topic for sure. Thank you all for your participation today, and we'll reconnect with you at 12:45.
Thanks, everybody. Go stretch.
Yeah, thank you very much.
Thank
Have a great
you.
day. Wonderful day.
All
Do
right,
something
bye-bye.
for your wellness.
Bye-bye.
Thank you.